Evening, guys. How are you?
Evening, evening. How are you, Chad?
Good. Sorry, I'm a bit late. I was just on another call. Hope everyone's good. Hopefully,
Yeah,
everyone joins again tonight. And guys, sorry about the material and access to the material and so on, and some of the small technical issues on the LMS. Joe is actually actively in Kenya at the moment, just sorting out some stuff for the team. And we've also brought in another administrative support individual to help Cindy, support Cindy, because there was a bit of capacity challenges on her side. So yeah, there'll be someone called Danica. She'll be engaging you guys from next week. Um, so yeah, so she'll be solely focused on you guys. Yeah, so that'll be hopefully resolve some of the small delays and yeah, communication delays we've had. But yeah, hope everyone's good. How's
yeah,
Kenya?
good, good. Kenya is good, actually. I'm coming from, actually, whenever I'm here, somebody always finds that I'm here and they're like, oh, can you do a quick patient consult? So I just came from one of the teaching hospitals here doing a triplet consult on, actually, it was supposed to be triplet, but it turns out it's twin with twin to twin transfusion. So yeah, we have to yeah, intervene rather quickly on this one.
Oh, hectic. Oh, wow. Okay.
Yeah, so it's yeah, I mean it still gives us a good case studies and things like that. But you know, the thing is when you get out of South Africa, you realize that medicine in South Africa, how much we complain about it, really is advanced comparatively speaking to
Mm.
the rest of Africa, you know, the way we practice medicine. So, but that's why we teach, right, Chad? That's why we teach.
Yeah, that's why we teach, man. That's why we teach. Um, yeah, I think how many is on the call now? I'm struggling to. I'm having some issues with my teams, but I think Joe, if you wanna, you can decide when you wanna kick off. Once you feel that there's enough people on, and then we just make
Yeah.
sure that we're recording, we're recording the session and all of that
Yeah.
stuff.
So let's give, I have 11 people on right now, including you, Chad. So, oh, no, 10. 10. So let's give like 2 more minutes and then we'll plow into it.
Okay, cool. Let's do that.
I'm going to put myself on pause while I get a cup of coffee here. Okay, guys, so I think we can go ahead and start. I'm glad that you guys are back, and it's always good to see, you guys back for, second, third, fourth sessions in these things. It's interesting that we were speaking today as I was in Kenya on what it is that you're doing in South Africa. And one of the institutions that I was with today, which is a large institution called Equity Afia, was actually very enthralled with what it was that you were doing because they said, look, we have never thought of doing something like that here in Kenya. How can we put something like that together? So Chad and I were speaking about today trying to do something like that in a broader sense because it's still doctors that are having challenges finding healthy occupation. It's still medical officers and nurses also in the same realm. And I think I'm very, very congratulatory to you guys for actually taking part in something like this because it's not everyone that would take the time out to do something like this. A lot of people would just kind of give up and, kind of wallow in wherever it is they found themselves. So my congratulations to you guys. And I wonder before we start, you guys all have mic access because I think the teams on our company side does not automatically grab access when we do webinars. I wonder if I could have one or two of you guys just before we dive into this tonight to give me like what are the reasons that you guys are doing this? Because obviously it's not being done anywhere else. It's really a rare thing, especially on this continent. So since you guys have all mic access, I want to hear from one or two of you as to why is it that you're actually doing this? Both the ultrasound part, the business part, what brings this together for you guys?
Hi,
Hello,
can you hear me?
perfectly loud and clear.
My name is Minenke. I am a year out of ComServe
Mm,
and have moved to a different province and have been struggling to find permanent employment since, I'd say, August last year.
mm,
So I've been locuming at one institution really because just the overwhelmed feeling of being unemployed, number one, out of the provincial system, number two, into private practice. It's just been very overwhelming and has affected not only financially, but also emotionally, psychologically as well. So, being in a practice and seeing some things that are lacking, such as POCUS. We have a lady in our institution who comes in to do fetal ultrasound. So they have to outsource such a person, you know.
mm,
And I saw a gap there.
mm,
If I stayed on long term, or even if I ever thought I could do my own thing and hear the things that I'm seeing in this practice that are lacking, imagine how much more effective my own practice could be one day. So not just the
mm.
ultrasound, but also the business side of things. So I thought this was an amazing initiative, and thank you to my colleague who gave me your details. And I really look forward to learning so much from you guys. Thank you.
It's a
Oh,
pleasure.
thank you.
You can't say one day, Manisha. It's your practice starts when you guys leave here. So your practice, your own business is a few weeks away. Um,
Oh yeah.
so yeah, no, I'm just kidding. But no, it is really it's awesome to hear that. And just want to second what Joe was saying. I know we've said it before, but it is truly uh, just a different. It's 2.0. Like this is healthcare delivery 2.0, and some of those pain points you guys feel are obviously pain points we identified and were the reasons why I created this in the first place. But beyond that, it was just a case of empowering you guys and empowering doctors to be a bit more independent. Um, And I think as a business person, for me, like I think when we were doing our business bootcamp, we were talking about the value proposition canvas and all these things. And I think, Joe, for me, looking at my value proposition to the doctors, I did a parallel where I said my value proposition or this model's value proposition to you, and then your value proposition to your customer, to the market. And they are both, I mean, there are value propositions on both sides. So, I mean, I did a thorough analysis, and it took a long time, it took 2 years basically to say, okay, I actually can bring value to this now, and we can do it. So I think the doctors that you're asking now that have stepped in and so on, they're coming from a point of I think probably realization that the market is not going to change in their favor per se, and that they need to change it, which I think is remarkable. So yeah, no, Minesha, that's awesome to hear that. Well done.
Definitely well done. I'm very proud to be part of this initiative, Chad, because I think this is going to change the way medicine is practiced. I mean, if you want to change medicine at the primary healthcare level, you start affecting it with the little things. And the young doctor just said that she saw in the practice that they were locuming out fetal care. We know for a fact, I mean, this is evidence-based practice, that in China, point of care ultrasound is instituted at the majority of institutions. We know in the US, point of care ultrasound, I walk into any emergency room in the US, all the emergency room doctors are using handheld. There's one hospital that I went to in the US, and they had the handheld on a desk charging. And so the doctor would just walk by, grab it, do a quick exam, put it back on the charger, write it up, keep going.
And that's
Yeah, it's amazing that Africa is just now catching on to this, but you guys are at the forefront of this, and it's general practice. It is not high risk practice. It's general practice. Patient comes in, has a right lower quadrant pain, you put the transducer down. Oh, it's a gallstone. Now you don't have to waste time sending this patient to radiology because we know exactly what the problem is and we know how to treat it. Either we take them to theater or we tell them they're going to have to live with gallstones for the rest of their life. It's the treatment is very easy when the diagnosis is easy. But if the diagnosis is never made, one of the things we know for a fact is that over 50% of ultrasounds here in Africa never make it to the sonographer. They never make it to the obstetrician. They never make it to the radiologist. They sit undone because the primary care physicians do not know how to do it, and they don't feel comfortable and confident doing it. It's not like they don't have the tools. How many different ultrasound companies are there that make ultrasound equipment? A lot of them, even ones we don't even know the name of in China, Australia, Japan. We have the tools, we just don't have the confidence. So hopefully we can arm you guys not in these little sessions, but in the long run with the confidence that it's going to take to do and to basically make sure our patients are being taken care of in a good way. So thank you. One more from one person before I start, because this is also very, it it just tickles me to hear things like this, Chad. Any other of the doctors, why are you doing this? Why is this important to you? And sometimes it goes beyond just there are jobs out there that you're not getting. What are some of the other reasons, guys? I have everybody's mic activated now.
How's it, Joe?
How's it?
Chad?
There we go.
I'm good, thanks, and you guys. Thank you so much for the teaching. So basically, for me, I think I just made the cusp. I'm 35 years old, so not fresh out of ComServe, but yeah, toward the other end of the spectrum. And most of my experience was in the public sector. And I've always had a desire to work within the public space, within the, lower kind of SES, lower socioeconomic communities. And I enjoy working with public, but the environment was always just very, very toxic. And yeah, so I kind of feel like this is an opportunity to get back into that space, offering amazing tools like this ultrasound to communities that couldn't necessarily access it. So that's one aspect. And the other one was the business side of it. Just the fact that we're really not prepared to tackle and navigate private practice. So I did try and start my own practice after kind of really giving public a go and not doing well. And it was just very overwhelming. So the business side being bolstered, plus this ultrasound as a clinical tool, I was so excited when I saw this opportunity. And yeah, just very grateful for both the business side and the ultrasound. Yeah.
Wow. Thank you so much, my friend. And let me ask a question, piggybacking on what you just said. One of the things we talked about, and Chad and I talk about this quite a bit, as well as some of the entrepreneurs in East Africa, where I travel quite a bit. Why are we not as entrepreneurial as the rest of the world? What is stopping us? What is stopping us? We have more opportunity in healthcare in Africa than anywhere else in the world. Nigeria alone is projected that their population will outgrow China in 2040. So if you're talking about patients, you have more patients than anywhere in the world in the continent of Africa. Why in healthcare is our entrepreneurism restricted to such a small, narrow window when the rest of the world is taking massive advantage of entrepreneurism in healthcare? Massive advantage. I mean, you go to the Middle East, you go to Europe, and there are companies doing things that we've never heard about here on the continent because we just don't know. And I think it's that kind of, and I don't mean this in a bad way, that kind of ignorance that keeps us trapped. And so things like this that Chad has put together to actually increase the knowledge, to actually make sure that we take this healthcare entrepreneurism to another level, and also to make sure that we make maximum impact when it comes to patient care. This kind of thing is invaluable. So thank you, Chad, and thank you, all of you who are involved in this. I actually look forward to seeing you guys in 2, 3, 5 years where you'll be in this kind of practice. So thanks a lot. Yeah, man. I think, one of the things we need to wrap our minds around, first of all, is that this kind of education that Chad has set up, that my team puts together these educational webinars, it's not to be the end all to your learning to when it comes to point of care ultrasound. There's no way that, I've been training in ultrasound and teaching sonographers, radiologists, all kinds of physicians in Africa and the Caribbean for about 35 years. And one thing I do know is that there is no way that this kind of stops online or even with 1 or 2 online sessions, in-person sessions. This kind of learning goes on and on and on, and you're going to learn something every single day that you're in practice with that with your hands. After almost 40 years, every time I walk in and do an ultrasound or I read an ultrasound, I learn something different than I didn't know yesterday. So be open to continued learning in this. There's never going to be a point. There should never be a point where you get to anything and say, I know enough. Okay, so I want to start off by saying that. I'm going to queue up my system. I'm just restarting one of my computers here that's hosting the, 1 second, that's hosting the PowerPoint. Give me 1 second. Okay, powered up and ready to go. So for general practitioners becomes a very, very important thing because it can really improve the diagnostic accuracy of whatever medicine that you are practicing. Whether you're doing cardiology, whether you're doing vascular, whether you're doing abdominal medicine, whether you're doing obstetrics and gynecology, whether you're just basically doing emergency medicine, we know, and it's been proven, it's been written up, that point of care actually improve the diagnostics of what we're doing, and it's kind of a proven fact. And One of the things that we're trying to teach doctors and nurses is how to utilize that in the avenue that you find yourself in. POCUS allows for real-time imaging at the bedside, just the synonymous to using a glucometer, synonymous to using a stethoscope, synonymous to just doing a bedside blood test or a finger stick to get a quick decision. Point of care is just that. It is for a quick decision. Nobody's expecting any doctor, any physician on this call to go in and become a radiologist. Let's just grasp that for a second. So with point of care, we have a couple of things. First of all, you have improved diagnostic accuracy and speed. In the hospital that I used to run in the US, one of the things we did before I left, and I didn't even know it was called point of care when I was doing it, but actually that's what it was. We discovered that there was a huge backlog in accident and emergency. And you can imagine if you have a hospital with about 350 beds and you have a 24/7 emergency department, there's going to be backlogs at times because you can't get things through that department fast enough. So we actually did a study. Our directors came together and I said, guys, do a study. We're getting hit when it comes to patient satisfaction in the emergency room. So they did a study. And we got all our directors together, all our heads of department that refers into the emergency room, all our consultants. And we found out, guess where the bottleneck was? The bottleneck was in diagnostic imaging because a patient would come in, the doctor would do the test, right? And then the doctor would say, you need to go to radiology for, you name it, a chest x-ray, a KUB, abdominal x-ray, spine x-ray, whatever it is. You need to go to radiology. Then when we started drilling down, we found out that there was one modality in radiology that was holding up all the emergency room times, and that was ultrasound. Because one, there wasn't enough ultrasound technicians, ultrasound sonographers to start ultrasounding all the people that would come in. So people would have to wait. So you came in with lower quadrant pain, anything that was non-emergent, you would have to wait. And not only would you have to wait for the ultrasound, you would have to wait for the line to get into ultrasound because we only had 4 ultrasound technologists with 4 active rooms. Then you would have to wait for the ultrasound to be read by one of the radiologists. And every radiologist, we had 6 of them, was reading MRIs, CTs, they were reading MSKs, they were reading obstetrics, they're reading a lot of different ultrasounds. So yours had to wait in turn. And by the time you realize it, you've already been waiting an hour and a half in the accident and emergency queue. So we decided to fix that. We said, okay, let's take ultrasound and let's divide it out. All the complicated fetal anomalies, fetal echocardiograms, complete vascular exams, carotid arteries can go and get done. But we're going to keep and at that time, we didn't even call it point of care. We said we're going to keep the simplistic exams and set up 3 ultrasound bays in the emergency and accident room and have all the lower tier ultrasound been done in that space. Well, we did that research and study and auditing, and over the next 2.5 years, we actually brought the wait time in ultrasound way, way down. Why was that? Because we were now doing point of care. We trained all the doctors doing point of care at the bedside with, at that time, we didn't have handhelds, we had laptop ultrasounds. So they were all doing point of care with their laptop ultrasounds at the bedside. And then those people did not have to go to the radiology department. So we discovered, quite by mistake, that point of care ultrasound became something that was our bread and butter after that. We trained all our doctors, we trained a couple of what we call our PhD nurse practitioners, and we trained a few of our residents, our emergency room residents, to actually do this to bring the wait time down.
Can I just make a comment there, Joe? So
yeah,
it even goes back to Joe's talking about they were using laptop-based things and all this. So back in 2018, I think it was 2018, was when I sort of started exploring the world of developing POCUS device and getting involved in it and so on. And I think at that time I still had my experience in the EC where I didn't have a device, I didn't have equipment, and in that moment I decided I wanted to introduce POCUS onto the African continent, which we did do over the last few years. But I got a message from one of the doctors now on WhatsApp asking about a device, and I was just thinking back to Joe's point on the simplicity. So when I got into the space, I actually contacted all the biggest brands, and Joe and I had this discussion like a few years ago. All the biggest brands, GE, Philips, Butterfly, all these big brands, and none of these devices were actually appropriate for the African context. So they were too complicated. They had too much stuff on it, and I actually, because I had some relations with some factories, I actually was connected with the CEO of one of them, and they had just started ultrasound manufacturing, chip-based ultrasound. And I started working on it with him. I had no money. I had no resources, really. I was just a doctor in South Africa that saw an opportunity or a gap for POCUS to be introduced. And this sort of started the journey of collaborating with this factory, building version 1 and getting it to market and all these things. And I think the African context is so different to the US and first world countries just because of the way care is delivered. So in our setting, the GP or the nurse, even sometimes, the GP does a broad array of things, whereas in the US, you go straight out of pre-med into med and then you're specializing. So everything is in a specialist realm. And the devices and equipment and everything is built in the same way, right? So some of the other brands, which Joe works for the IFC, which is the International Finance Corporation, worked with him, and it's pretty much engaged with probably every single ultrasound brand in the world, like literally. And I remember Joe, we had a big project we were doing with Unjani, and Joe came back to me. He's like, I didn't know Joe at the time, and he was like, "This is the device I want to use because it's so simple." And that was really the angle. So we were looking at whole body scanning, something that was robust. Back in the day, when I used to do like, this is like 2021, 2021, I did a presentation at the Department of Health in the Western Cape, and I remember throwing the device, and I threw it on the floor, just to prove its robustness, because one of the doctors said to me, if this thing can survive a week in Kailicha, then I believe that it's something that we can use. And I said, let's do it. And so I think there's been an evolution. You guys are getting sort of the second gen of it now, but there was an evolution of the introduction of POCUS. And I'm just piggybacking on what Joe was saying. When they identified it to be something that could be of value, it was before it was seen as something that could work. So a few years ago, there was tons of pushback for the use of POCUS. I mean, we did a lot of work at a policy level where POCUS wasn't even allowed. Remember, Joe, like it wasn't even. We had to get it. We had to get it passed through, like on a ministerial level, to get POCUS to be seen as okay, and not just for doctors, even for specifically like for nurses and things to use it. So yeah, I just thought, because I'm just piggybacking on what Joe was saying about at the time when they realized the opportunity was there and the need for it. Mine was pretty much the same, but there was a big adoption element to it. So we really drove adoption of ultrasound, POCUS specifically in sub-Saharan Africa, and that's how I met Joe, because there was no market for it 5 years ago. It didn't exist. So I think this is now sort of a product of quite a few years of like pushing against the resistance, and then eventually, the floodgates open. So yeah, it's definitely, the time is sort of now. It's a now thing, if that makes sense.
100%. And Chad, I can say that that's mimicked all through Africa now. East Africa is seeing a big adoption in point of care ultrasound. We're getting requests from other African countries. And in Kenya now, the government, and Chad is completely correct, it is written now into MOH policy that doctors and nurses that are outside radiology must learn to do POCUS through a legitimate POCUS instruction course and then also be certified. Because they're realizing that there is not enough radiologists or sonographers or obstetricians or whatever the medicine is to be sustain patients. It's just not enough. So what's the other ways to teach non-radiology, non-imaging people how to do this and how to do it at a scope practice that it can be managed in. So yeah, so we're definite now is definitely the time. We know absolutely that POCUS is useful in identifying quick conditions, which is exactly what we're using it for in this contents. We also know that it enhances patient care. That's something that I know for experience because I feel naked when I'm doing rounds in the hospital when I used to practice, especially when I moved to Africa and when I was practicing in the Caribbean, I was consulting, overseas. If I didn't have access to an ultrasound, no matter what specialty I found myself in, I felt completely naked because to me it was like practicing practicing medicine without ultrasound to me is like walking into a dark room without a flashlight. I don't know what's going on. And if I can turn that light on and get a hint, even a differential diagnosis, it may not be the complete diagnosis and it may not be the most accurate diagnosis, but it gets me in the right path. If a patient walks in with rebound tenderness and I can do a quick ultrasound and identify a little bit of free fluid in that right lower quadrant, and they had that rebound tenderness to where they're screaming when I pull the transducer off of their stomach, then I pretty much know if I'm looking at that white blood count and it's elevated, that patient's got an appendicitis someplace going on. I just need to find it now, right? So I think that this is what I'm trying to get across to you guys is in your scope of practice, you're going to use this tool to put you on the right track of whatever differential diagnosis it is that you're trying to make. It's also we know that POCUS is also help guiding procedure, right? So that if you're doing, let's say, a fine needle operation with your GP, or if you're doing an abscess drainage, something like that, where you feel that you have to keep an eye on what's going on, then the easiest thing to do, the very easiest thing to do is to use an ultrasound probe to do that guidance because it is so easy when you see what it is that you're doing. I told you guys last when I was doing residence, what I hold on one second. Yeah, what I did is I actually on chickens just sure that they knew how to position that ultrasound and how to make sure that that ultrasound was in the right place. This was before the days we had ultrasound needle guidance and things like that on our machine. So I'm saying that to say this, guys, as I start off with this particular lecture, is that ultrasound basically has its pluses when it comes to point of care, cost effective, easy, quick diagnosis, yes or no answer right off the bat. You can do this. Okay, you can definitely do this, but you will not get all this training on this. In fact, I'm going to go through some things that's probably going to frustrate you because you can't see it. It'll become more apparent when we do the hands-on, and even then, it's just minimal exposure as you go through your practice and as you seek guidance and as you continue to learn, become even more evident what you can do with ultrasound. So this evening, I kind of want to talk about, and Dr. Ted from our team put this together for you guys. I kind of want to talk about abdominal and DVT POCUS for general practitioners, because I think that those are two of the areas that if you're doing general medicine, you'll hit those pretty much all the time. In East Africa, we train on three topics usually. It's general obstetrics, it's abdominal, and then it's how to rule out deep vein thromboses because we find out that in general practice, that's what most of the patients are presenting with. Those are some of the diagnoses that you usually come up with after doing point of care ultrasound. So basically, I want to arm you with just the basic knowledge, right, of how it is that you're going to proceed if you have a patient that comes in that needs one of these ultrasound, if you have a patient that comes in that you're going to suspect that, this patient has a swelling, this patient is going to need an abdominal, this patient is going to need something else than just normal, everyday, put my stethoscope down and see what's going on, right? So abdominal and DVT ultrasounds, as I said, will be probably one of the predominant things that you guys get when you're doing just general practice. So first of all, we have to understand, and this is a review, basically, and I hope everybody can see my screen. We have to understand point of care ultrasound and its clinical advantages. As Chad said on the last time we met, you're going to get pushback. You're going to get radiologists, sonographers, obstetricians, people that are already experienced in ultrasound to tell you that you should not be doing this because one, you don't know what you're doing. Two, you're going to steal their jobs, which we know is not true. We have proven here in East Africa that it is exactly the opposite. To teach people to do point of care ultrasound actually creates more of a steady stream into radiology than it takes jobs. We know that people that do POCUS ultrasound here in East Africa, if obstetrical ultrasound, most of your patients that you get would normally ever go to get a regular ultrasound from a doctor because most of them are confined to the rural areas. Most of these young ladies that are ending up with the midwives that are learning ultrasound and with the obstetric doctors in the rural areas don't usually go to big hospitals. They're confined to that area. So that means if the rural area and if the general practitioner does not know how to do an ultrasound, they're never going to get it. So we've now realized that in establishing these people to learn how to do POCUS, we create a strong referral package, strong referral between the midwife, the general practitioner, and the radiologist and the obstetric doctor. We create referral pathways. So what are the key advantages, clinical key advantages of POCUS? Very, very simple. If you really, really think about it, what do you need to do, right, to see those POCUS advantages, especially in the clinical sector? Well, number one, it's portable, right? That's the best thing for me because I remember back in the day when I graduated school, ultrasound machines were not portable. They were huge, huge pieces of equipment that to me, they were put in this big plastic case and all they had was buttons. Some of them had more than one screen and it was all a big computer. It looked like a big robot, basically. So it was not portable. So if you needed an exam in accident and emergency, you'd have to push. As residents, we had to push these great big honking machines back and forth through elevators, through lifts, into departments. So nowadays, point of care is completely portable. Whether you have it on a laptop or you have it on a U-Image portable device, it is compact. And basically, we can keep it in a drawer. I know a lot of doctors here in East Africa just keep it in their pockets and use it with their cell phones because it is portable. So that device is available for immediate bedside diagnostic insights. Number two, because it's portable, it enables rapid and real-time visualization. It provides instant image of internal structures to faster clinical decisions. Why do I need instant imaging? Well, I need instant imaging because I need an instant answer, right? I need an instant answer. I don't want to have to sit around and wait if the patient is complaining about something. I want to use it. Can you imagine if you had to wait for your stethoscope to warm up or you had to go grab a huge thing to actually listen to a patient's chest or listen to the gastric sounds in the abdomen or listen to their lungs? So because point of care is so portable, it's going to provide instant imaging of internal structures. And what do you do then is you're going to support faster clinical decisions. Okay. So we have the fact that it's rapid, the fact that it facilitates very, very decision making, right? I know what to do. I don't need to wait. I need to know what to do right now, right? So if I need to know what to do right now, I need to have something that is able to keep up to what it is that I'm doing. So it's going to facilitate clinical decision making, okay? Chad, can you actually mute your mic? There's a little noise coming on your Are you able to mute your mic? Perfect, perfect. Yeah, you can unmute when you need to speak. The other thing is it's widely used across medical specialties. Do you remember and those of you who are young may not remember this because you guys are still young, right? But I remember when you said the word ultrasound, you only thought about obstetrics. You only thought about a GYN with a lady with a big belly on his bed trying to figure out where the baby's head was. And you had this gray kind of image that you couldn't even see. And you're like, is that baby? Is that fluid? What is that? Now it's used across, I cannot think of a medical specialty that ultrasound isn't primarily used in. And if you can find one, please let me know. But most of the medical specialties now, even as we talked about MSK, we talked about cardiac, we talked about vascular, lung imaging now is a thing. There is now a special lung imaging certification that's worldwide available. Every specialty you can think of in primary care is getting to be ultrasound dependent. You have primary care, you have emergency medicine, and you have all the other specialties. The next thing is it's portable and it's non-invasive diagnostic tool. In this day when we're worried about green effects and we're worried about energy transmissions, we're worried about exposing patients to radiation. We don't have to worry about any of that in ultrasound. And I know that you guys have probably heard about, oh, ultrasound heats up tissue and you can't scan a baby for too long because it's going to give the baby, birth defects. I can tell you that in my specialty, I have done fetal echocardiograms that have taken 2 to 3 hours to do, simply because when you're doing a fetal echocardiogram, there's so many little minute vessels in and out of that fetal heart and the cardiac cavities that have to be measured. And you've got to measure the ejection fractions. You've got to measure the thickness of the walls, where the tricuspid and the bicuspid come in, the width of the cusp in each of these. I mean, it's a lot of minute measurements that you're doing, and you're doing it reminded you're doing this on a fetus that doesn't know that you want it to stay still. It's always moving. And I have not seen one birth defect come from any of those scans, no matter what anybody says. And none of you are going to be doing 3-hour exams. So that invasive thing where a lot of scientists were saying years ago that ultrasound causes cavitation and things like that is completely, in the words of this clinician, nonsense. Okay. And then the last thing is it improves bedside diagnostic accuracy. Sometimes my patient will have a pain, and by the time they get to radiology, the pain is either deferred or it's transferred or they don't feel it anymore. They're too sick to tell me where it's hurting. But if I have that ultrasound at the bedside and that patient is talking to me, I can use it right then and there really quickly to figure out what it is that's going on. So let's recap. 1, it's portable. You can use it at the patient's bedside. 2, it's rapid, it's quick, it's real time. I don't have to take a picture and wait for it to be developed. 3, it facilitates very fast clinical decision making. In the case of, let's say, a dissecting aorta or a ectopic pregnancy, I need to make decisions quicker, right? And ultrasound enables me to do this at a point of care scope of practice. 4, it's widely used across every medical specialty that I know of right now. 5, it's non-invasive. I don't have to worry about radiation or anything, or taking somebody in the MRI tower. And lastly, it improves the accuracy of that bedside diagnosis. Now, we know, all right, just from studies, that ultrasound is in some cases even better than MRI. MSK ultrasound is said to also now be leading MRIs because it's less expensive, it's quicker. If a patient is having tendon issues, tendonitis, muscular issues, inflammation, I can actually ask that patient to move and watch the movement of that tendon, watch the movement of the fluid, watch that movement in real time on ultrasound. Whereas in MRI, I can't do that. I can't tell a patient to move in MRI because they have to remain perfectly still. I don't know how many of you have had an MRI. I've had the displeasure of having 2 in my lifetime, and it is not a study that I would wish to repeat. I'm not necessarily claustrophobic, but that thing made me claustrophobic. And the fact that you can't move is just, to me, when you tell me I can't move, it now heightens my anxiety. This is why a lot of patients in MRI have to be sedated. You don't have to worry about that for ultrasound. Why does point of care ultrasound transform primary care diagnosis? Well, we already said when it comes to abdominal and deep vein thrombosis accuracy, it actually enhances the accuracy of these two things. If I'm looking at the abdominal cavity, if I'm looking at vasculars to rule out thrombus, to rule out blood clot, it definitely scientifically improves my diagnosis. We know, according to NIH, the National Institute of Health in the United States, that there's a 30% improvement in abdominal diagnostic accuracy when I'm using ultrasound. That's 30%. That is a big improvement. That means you're getting 30% more of a diagnostic accuracy when you use point of care ultrasound versus when you don't do anything and just send that patient through the normal care referrals in the hospital. The second thing is you have to consider this too, because I was actually looking at this thinking, how many times have I done this, but I've never thought about this. It enables faster patient care. And business-wise, what does it mean if I can see a patient faster? These nurses in rural areas are seeing 30, 40, 50 patients a day, right? And they have to slow down to make a diagnosis. That's money they're not making. So, as doctors that are going to have pretty much your own businesses, if you can actually speed up the care of that patient through there, if you don't have to sit there and press on the patient and try to find out if they have rebound tenderness, trying to find out if they have a palpable mass, you can put that transducer down on the thyroid and say, yep, you've got, thyroiditis, you've got your thyroid is enlarged. You can put the transducer down on the right upper quadrant and say, yeah, you have gallbladder thickness, there's a polyp in your gallbladder. You actually increase that patient's throughput, right? You decrease their wait time, you give them faster care. Remember, we said quicker diagnosis, shortening the patient's wait time. And everything is about patient-centered care now. It used to be that I, as a diagnostician or a clinician, I didn't care. I would just say, look, this is what you have. Let's get this patient in. Let's get this patient out. But we can't do that anymore. We don't have the luxury because patients can choose where they go. They don't have to come to you. And most patients are going to go to whoever makes them feel better, not necessarily makes them well, but makes them feel better. I found out that when I pull out that ultrasound and the patient kind of looks at me in shock, is like, what's that? And now they're curious. Now they're seeing this picture. Even if they don't understand what the picture is about, you've now held their attention. It's about the patient. I don't want to make any mistake about that. It has always been about the patient. It's just that in these days or times, since we're realizing that patients can go anywhere they want a lot, why should they come to you? Because you have the capability to make them feel better. One of the bigger hospitals here in Kenya, it's called RFH, and they have 12 hospitals in their system in Kenya. The whole reason that he adopted point of care for his obstetricians and his emergency technicians is that he said that it makes the patient curious about why they're getting so much better technology at his hospitals versus going to a regular hospital emergency room. And just because of that, he finds that patients prefer to get their obstetric care at his hospital because his obstetricians now know how to use point of care ultrasound. You see what I'm saying? So it becomes
Can I make a comment here, Joe? Sorry. That's actually when you guys engage your GPs, that's actually a very important thing you guys could kind of bring across when you're doing your discussions with them. And to reiterate what Joe's saying, on our side, and it's all our doctors have experienced the same thing, the look of absolute like wonder on this patient's face when they see this little thing pop out. And the doctors often keep it in their top pockets, or they just take it out their back pocket, like Joe said, like a phone, and they attach their tablet and they do the scan. Sometimes they even ask the mom to keep the tablet and do the scan.
Yes.
It's an absolutely incredible thing for this patient to see or the customer to see. And the net effect of that, I think, for the GPs and the guys you guys are doing your deals with, is that it's going to ultimately enhance that patient's experience at their practice, number one, and it's most likely going to keep them coming back. So, and they're going to go talk about it, right? So they'll tell their friends and family, no, the doctor there, they have this amazing thing and they use
Yeah.
it. And I got to see the image, I got to see the scan. Or maybe even if you do something simple like an implant, right? You put in an implant or you take out an implant using, ultrasound guided removal. It's such a simple thing to do. Our doctors pick that up without even training for it. They just, once you understand the basics of what you're seeing in front of you, they started getting tons of referrals for implant removals to some of our branches because no one else was doing it. And the patients started talking about it. No, but that doctor uses a fancy machine to do it. So it's a big plus point. And customers, patients are getting smarter. They want to feel, that their doctors are on top of it. That's what gives the younger doctor the edge in today's world, because as much as the older ones and the established ones do have the relationship and they've been there for years, they also can't keep up anymore because customers have different requirements now. Patients have different needs. So that's definitely a very important point that Joe makes there, and I think it will help you guys in your discussions with your doctors.
100%. Let me ask a quick question, guys. Let's ask a fun trivia question because I'm a big TV. My wife says I love to watch TV more than I like to read. It's simply because when I come home, I don't want to have to think, right? I've been thinking all day. I just want to have my brain veg out. How many people, and just do your raise of hand on your device, if you can raise your hand. How many people know who Gene Roddenberry is? And I'll give you a second. Because if you guys are probably in your 30s, you probably wouldn't know who that was unless you're big TV holics. How many people know who Gene Roddenberry is? See how many people raise their hands actually for that. Chad, do you know?
I've never heard of that name in my life.
Oh my God, so young, man. You're so young. Oh, God.
We only
I
know
see.
30. We just touched 30 now. So you're giving away your age.
Yes, I am. Let me bring it down a little bit more. How many people remember the show Star Trek? I know somebody's got to remember that show, Star Trek. Yeah, I see, Chad, you have your hand up. Who else has a hand up? You're telling me that nobody else remembers Star Trek? Oh, that's two. Okay. So, yep, there we go. There we go. Okay, not too bad, not too bad. So Star Trek was one of these shows that, yeah, Muhammad, thank you so much, man. I don't feel so old now. I grew up with Star Trek, and one of the things when I was growing up that always interested me, Star Trek is a futuristic show written by Gene Roddenberry, who was a science fiction writer and has passed away. He wrote a show that he basically visualized a world that would be, with fusion power, with atomic energy and things like that. So he wrote this show a long time ago. One of the things that always intrigued me, and I remember I must have been like 19, 20 watching this show thinking, and this is when I was thinking about going into medical school and things like that. The doctor on the show, if anybody was injured, he would, they would come into the sick bay of the ship and he would pull out this thing that I swear to you, Chad, now looks like a old GEV scan, flip it open, and then he would put the probe on the patient and look at this thing and said, oh, no, she's 4 weeks pregnant. Oh, no, this patient is getting ready to have a heart attack. And I thought to myself, back in the 80s, how cool would this be if I could actually do that with something? Now, fast forward, this is 2025 we're looking at, and we have that same thing that Gene Roddenberry thought about in the 1970s. It has now come full circle, and we can actually do that. How cool is that to be living in this day and time? That is so cool to me. So let's take advantage of it. Definitely let's take advantage of it. Now, how many people, and you don't have to put your hands up for this one, but I know you do. You can't tell me you're a doctor and you didn't. How many people used to watch Grey's Anatomy when it first came out? I remember when Grey's Anatomy came out, we used to take lunch breaks and record it and then go watch it on our lunch breaks when I was working. At that time, I was working in a high-risk fetal center. And we used to take time out from the patients to go see it. So if you remember Grey's Anatomy, you remember that in the emergency room of Grey's Anatomy, they had all these surgeons, which I think when they wrote that, they didn't consult a regular doctor because surgeons do not hang out in the emergency room, right? And anytime a patient would come in, that surgeon would grab an ultrasound machine, which was like a handheld thing, which I had never seen back in those days, and actually look at the patient. And I'm thinking to myself, that's cool, but that doesn't work. Now it does. Now you have the capability to do that. So as I was saying, then you become less dependent on the radiology department. Not saying that we don't need the radiology department, but we shouldn't be sending every patient that needs an ultrasound to the radiology department. There are some things, patient comes in with a swelling on their arm. They should not go to the ultrasound department. You should be able to pick up your transducer and tell, oops, that's an abscess, that's a bee sting, that is whatever, you can fill in the blank. There was one case that we had in one of the hospitals that I worked at where I was in the psych ward doing rotations. And this young gentleman came in, must have been in his 20s, but he was clearly, you can tell he was clearly of mental deficit because his helper or whoever that was that brought him in said a couple of days ago, they were missing they looked at the plastic fork that he was eating with, and they discovered that one of the sporks had broken off, the things had broken off the fork, and this gentleman had jammed it into his arm, but it was like a week later and it had completely healed over. There was a scab there, but in order to find this thing to take it out, they didn't want to just start cutting. So they wanted to send this patient to get all these studies. I said, no. Let's just use an ultrasound to see where it is. It's plastic. It'll show up on the ultrasound. Lo and behold, we found it, and the surgeon was able to mark the area and just basically sedate him for a second, cut it, take it out, sew the area back up, gone. It took it took me less than 30 seconds to find out where that thing was. So now we have an excuse, an argument, a justification for point of care ultrasound because we become less dependent on the need